Okay, so here we are doing our deep plane TriMax facelift. Remember, the TriMax facelift is a facelift that doesn't just lift, it shapes. And the way that we shape is by focusing on an important facial triangle that connects the malar eminence to the gonial angle, essentially to the genial region or the chin. So you can see how that's a triangle. What we do in order to maximize the appearance of that triangle, and what does maximizing the appearance of the triangle mean, by the way? It means creating some prominence in the malar region, restoring the volume and the fullness of the cheek, creating a little bit of a prominence in the gonial angle, therefore defining the line between the gonial angle and the chin, creating a beautiful jawline. And the way we go about that is we elevate the skin. This is what makes it a deep plane facelift, is that minimal skin elevation. And we enter the SMAS just about here and just about here, leaving ourselves an important tab like this that we can then elevate. We elevate deep to that SMAS all the way into the mid-face, all the way along the jawline, all the way into the neck. And then what we do is we do our important multi-step process where we first do our vertical oblique vector verification. So the face falls down vertically, but also inwards. And so we need to custom tailor the vector of the elevation of the SMAS. Sometimes it is purely vertical, sometimes it's vertical oblique. That's something that's customized to the patient. So that's our first suture, that's our first fixation point, is in the midpoint of the SMAS. If we do this suture first, the problem is we blunt the ability to heap up a small amount of tissue in the malar region, therefore limiting our ability to shape the malar region, limiting our ability to maximize that triangle. So that's our first suture. Second suture then anchors the rest of the SMAS in place, both of those to the deep temporal fascia. Then our next suture is the suture that's our stair-step postauricular suture. And so what that does is a suture that anchors to the mastoid fascia here. It goes back to the postauricular sulcus, trailing along that postauricular crevasse along the anterior medial portion of the mastoid region. Then it anchors into the earlobe. And this is where it's different. This is where it's different from other crevasse sutures. And it's not, I misspoke, it's not exactly the earlobe, but it's at what we call the incisure lobularis. So right in this area, we have the suture coming through, and then it comes down behind the gonial angle into the platysma. And with that stair-step suture, what's happening is we're pulling that platysma up behind the gonial area, gonial region, therefore creating a little bit of a fullness there that defines a nice distinct border between the face and the neck. We don't want a face that segues into the neck. We want to have a nice distinct border there. In addition to that, that suture, because it goes through the incisure lobularis, which means the crease between the earlobe and the face, because it anchors back there, it helps pull that region up and anchors it deeper so that we are much less likely to get a pixie ear deformity, malposition of the earlobe. And again, the reason it comes back here, the final portion of that stair step, is because we're able to maximize the fixation to the mastoid fascia so that everything's anchored to a really deep and thick fixed tissue. So that's suture 1, 2, 3. The fourth suture, just mid-body in the platysma, that goes straight back to the most posterior portion of the mastoid or even into the occipital region, therefore tightening the neck along this line here, creating a beautiful cervical mandibular crease and groove. Period, end of discussion.